Good afternoon, and thank you for joining us for today's webinar, Promoting Radiology Technologist Skill Qualification from Competency to Consistency. Before we begin, I'd like to go over a few housekeeping items. Today's webinar will be recorded and available through our website and the RadSite YouTube channel. To minimize noise and distraction, all attendees' microphones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using our Q&A box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, Dr. Mark Hyatt, RadSite's Chief Medical Officer.
Thanks, Kristen. I'm so pleased to be here with you to talk about promoting radiology technologist skill quantification. We're really talking about shifting the whole paradigm from just looking to assessment of competency to really assuring consistency. And by way of introduction, I'm really pleased to be the moderator of this panel of distinguished experts. As I said, my name is Mark Hyatt. I'm a radiologist by clinical practice. I've worked in a lot of different settings with a lot of technologists, all of which have been just superb people. I've worked in academic hospital setting, community hospital, outpatient clinic, and currently I serve as the Chief Medical Officer for RadSite, which is one of the handful of accreditation bodies deemed and recognized by CMS to accredit radiological facilities across the nation. And I'm joined with three distinguished panelists. I'd like to, each one of them to introduce themselves in turn. First, we have Matthew Hayes. He's the creator and president of ScanLab and Imaging U. Matthew, why don't you introduce yourself?
Thank you, Dr. Hyatt, and thank you for having me as a whole. My name is Matthew Hayes. I'm a technologist by trade, so I've been in the field for about 25 years. I've been a professor at the university level also for physics and things like that for MRI for about 15 years, all of a sudden. And I also worked for a major vendor for 7 years in terms of helping train from the application specialist to the customer. So now I'm here in Cary, North Carolina, right outside of Raleigh, and happy to be here and really excited to talk to everyone about skill quantification and what that means. Thanks for having me.
Thank you, Matthew. I'm sure your background, your experience will really lend itself well to excellent insights during this discussion. Secondly, we have Laura Casa. She is president of RadExcel. Laura, welcome.
Thank you, Dr. Hyatt, and thank you for having me as a panelist. So I'm Laura Casa. I am also a technologist by background, MR, CT, X-ray for 30 years. The last 20 years, I have spent in both clinical management and operations management, overseeing a large number of clinics, everything from acquisition through organic growth, as well as just operating and growing their volumes. And one of the big things we worked on was clinical quality and safety, and ensuring, standardization across protocols and technologist training, and ensuring clinical excellence. So happy to be here.
Thank you, Laura. Wow, and you and Matthew, we have both of you technologists, and you've worked for many decades with technologists. So this will be, I think, a very rich discussion. And then finally, we have Derek Rischel. He's Senior Account Manager for Subtle Medical.
I do metal too as well. So so thank you for the introduction. My name's Derek Rischel. I too am a technologist by trade. So started about 25 years ago on mobile systems. After 3 or 4 years of scanning, became application specialist, kind of overseeing about 20 scanners in the Michigan area. After my family got tired of the 9 months of overcast skies in Michigan, we moved down to Florida about 5 years ago. And when I did that, moved to the fixed radiology side of the business that I was working with. So in total, between fixed and mobile, we had about 400 scanners. And I started working on developing skills quantification for cross-training of our current team members as we tried to address the staffing shortage that everyone was working through. And then also started to roll out a remote scanning program at that organization as well. So we got that spun up to covering about 120 scanners remotely. At that time, moved to do some consulting on the remote scanning side, did that for about a year and a half. And most recently, back in October, I came to Subtle, medical, where I'm helping organizations use AI to improve image quality, reduce scan times, and really kind of track competency across imaging centers or enterprise.
Excellent. Well, I feel outnumbered as a radiologist. We have three expert technologists with a lot of experience. So in this session, in this webinar, we're going to be looking at why this topic matters. What do we mean by this new concept of skill quantification? We'll look at the old way, the new way, what the gaps are. We'll particularly focus on CT and MRI, look a little bit about remote scanning. All of you have that experience. Technology as a support tool, practical steps. We'll conclude with that for those of you listening that you can take back to your organizations. These are actionable, practical next steps. So with that, let's begin with why this topic matters. I could just speak from my experience working with RadSite, an accreditation body, where we're really beginning to deal with remote scanning and have actually issued standards for such. And we're seeing all different types of regulatory and accreditation requirements. But I'd like to ask my panelists, why do you think this topic matters now?
I don't know. I mean, anybody can go before me, but I think the three of us are very aligned in terms of what the core problem truly is, which is a lack of overall training, which ultimately manifests itself. I mean, the core problem is a change in and a lack of skill and a
Yep.
lack of standardization. And so I don't think it matters now. I think it's always mattered. I think the key here though is that now it's staring us right in the face, and we have problems with hiring, with retention, with investing in our technologists. I think now it's just coming more to the forefront, whereas before we've been able to sweep it under the rug, but it's been exacerbated by the tech shortage that is currently existing.
Right. Right.
Yeah,
And
I
and
agree.
But
yeah,
Laura,
sorry.
Laura, is it a problem? Is that true? Has this been a long-standing problem, but it's becoming more
So
prominent?
it has, and if you actually look back, it goes back to when the registry dynamics changed. Right. So now we have the programs with didactic programs and the clinical competencies, whereas previously, before that, it was a 2-year requirement before you could sit for your registry, and that lent itself to a lot of training, a lot of radiologist training with the technologist as well, where the technologist was working directly with that physician and would get immediate feedback on image quality, on protocol adherence, on why they're scanning the way they're scanning. And because of staffing shortages that started roughly 20 years ago, to get more technologists into these advanced modalities, while we shortened that gap during that time and created more technologists, unfortunately, we've done a disservice in the training aspect. Exactly like what Matthew said was, and that's really what's needed is that training needs to be there, that oversight needs to be there, whether it be from radiologist feedback, which is obviously right with all the remote reading and subspecialties, it's harder to do. You don't have a lot of that personal interaction any longer. So you need it with your senior technologist that can really train the technologists on how they're scanning, and especially as it continues to advance, especially in MRI, all the advancements of sequences and changing your parameters. It's not what it was 20 years ago. You've got to stay up to date. Yep.
Laura, have you seen specific examples in your work with technologists
Okay.
where you see deficiencies that need to be corrected, and there needs to be a new way to address them?
Yes, yes, and that's exactly in my first thought when I see this, is that okay, if fine, especially in the smaller imaging centers where it might be a single technologist, how do you train that single technologist? Well, probably to partner with someone where you can have a over-the-shoulder scanner, right? It's just even a remote scanning behind them to give them that immediate feedback and tips and help coach and train them along. They need that help. But meanwhile, they're trying to stay in business and keep patient access going. But to a disservice if the image quality is not good.
Yeah. Now, Laura, you commented on staffing shortages and this concept of remote scanning, all of which exacerbates, as Matthew said, this longstanding problem. Derek, how would you say that remote scanning has affected the situation of training of technologists and maintenance of their consistent competency?
Well, it's a bit of a double-edged sword. So, I've seen facilities that have used remote scanning for over-the-shoulder kind of expert
Okay.
assistance, where an offsite technology, because if we look back, Dr. Hyatt, before the Deficit Reduction Act, when I started in an MRI, I would work with three other technologists. And so when I was fresh out of school, my
Yep.
training didn't end on day one, and I was working by myself. I worked with other technologists that had a lot of experience, and so for years, I was working with senior technologists that were able to pour into me. But as the staffing crisis has morphed into a skills gap crisis, we're seeing a lack of technologist skill, and I don't think it's any of their faults, right? We don't have bad technologists. I think we have really poor training and we've set them up for failure in a lot of ways. So, one of the ways that remote scanning has been very helpful is you have a senior technologist that's able to sit at a scanner or sit at a command station and monitor three, four, six scanners at a time. So, if technologist A that's never scanned breast MR before has a patient come up on their schedule, that remote expert technologists can then remote into the session, can either take over the scan for them to demonstrate it, or can walk them through it if they have a little bit of experience, give them that expert opinion and support. Um, and uh, and then monitor, moving forward throughout the day, those multiple sessions. I've also seen facilities that have remote technologists as their sole staffing environment or staffing model, and they're contracting remote technologists, and there is no really oversight to quality of the procedures that are being done. So I've seen it both. I've seen both use cases happen, and so it can work well, or it can be, I think, detrimental to what we're trying to do.
Oh, for sure. Let's, we've all mentioned this concept of skill quantification. And I'd just like to get your feedback and insights as to what we mean by skill quantification and what it includes. Any initial thoughts?
Right. So I would say, obviously, uh, image. So there's a couple, right? It's when you want to quantify it, you need to have trackable metrics, right? So you would start with image quality,
Okay.
efficiency, protocol adherence, and then patient safety. I think those would be the four top that come to mind for me.
So let's repeat those. Those are very important. These are your
Mhm.
objective metrics. And what are those again?
It would be image quality,
Okay.
right? Efficiency, right? So scan time, throughput, right? Because it's all about patient access, right?
Right.
Protocol adherence,
Okay.
and then patient safety.
Okay.
So not in that order, by the way,
So
of
one, two,
importance, but
and four are, I think, intuitive probably to our audience. That third one with respect to protocol adherence, why is that important?
well, because if they don't follow the correct protocol, then the radiologist is going to struggle with the diagnosis, right? And that's the end result of any scan is to get a diagnosis, is to get, right, is that final report. That's the product, right? Of any imaging center, your final product is your report back to the physician, is images and report. But if you don't have good protocol, right now you're going to have to bring the patient back.
Yep.
So now you have a poor patient experience as well. Um, right. And if we're talking CT, now we're discussing right more radiation because we didn't follow a protocol. Um, uh, yeah. So really at the end of the day, is the best interest of the patient is that we look at those, at least those four. And I'm sure there might be more. Derek and Matthew may have
I, I,
others they would put in.
What do you think, Matthew? Do you think those four kind of are key?
I agree with those four just as a whole. I have a little bit of a different opinion there to where, one of the things that I've done all over the world is build protocols, and I've done it for a long time, and I feel like I'm pretty decent at it. But if I build you the best protocol in the world, and you are, first of all, there's no protocol that's good for every single patient. Um, and I understand why protocols need to exist. I don't have to like that, but I agree. I agree with why protocols need to exist. But if I have given you the world's perfect protocol, let's say just for funsies, and it's perfect for you, just happens to be. If I have a technologist that does not have the requisite training and skill, they're going to approach that. They're going to add 6, 10 slices that they don't actually need, that doesn't actually add to the report that Laura was saying. They're going to and sure, that is a report, but I was sitting next to a radiologist today trying to look at MS across from another imaging center to their current imaging center, and they could not even line up the plaques to be able to see them correctly because they have been done completely differently, and ultimately because of an overall lack of standardization that exists inside of MRI. So I agree that protocols need to work, but I also think that one of the core competencies of high skill technologist is the ability to adapt, to make that scan faster if you have to make that
Right.
still keep it diagnostic, but tailor it to the needs of the individual clinical scenario.
It's almost, Matthew, as if there should be maybe a fifth metric, that is that ability to apply, to have not only the art to your science, it's an art and a science, but to have some flexibility to adapt and to artfully craft the study, adhering to what is essential, of course, but sometimes to add additional things on the fly.
Yeah, I mean, I think you have to Laura's point. I mean, I think we both agree on. I mean, I think all of us agree on this stuff. But how do we have you? I think skill is recognizing pathology when you see it,
Yes.
and not when
Yes.
the patient is getting a call on their way home. How do we train you to have that eagle eye for pathology? How do we train you to recognize
Right.
artifacts and compensate for those? I
Right.
think the key to all of this is prospective intervention at the time, at the point of care, not when a radiologist calls me
Mhm.
2 hours later to say we got to bring this patient back, we missed something or something happened. And
Yeah.
that Go ahead, sorry.
Yeah, I think no, you're totally right. Totally right. I used to say that all the time. I don't need you to know the difference between a glioblastoma and an astrocytoma. I just need you to know that there's
Doesn't
something there.
Yep.
Something's there,
I,
right? This
I see
this
that
does
all.
not belong.
And to do additional specific cuts or slices through that area upon visualization of
Right.
that unexpected pathology. So maybe a
Right.
fifth metric could be that having that eagle eye or that flexibility to adapt. Now,
Mhm.
once you have these metrics, Derek, and I was wondering if you would add any, any additional ones, but then once you have them, how do you assess how well the technologist fulfills each of those? Image quality, efficiency, protocol adherence, safety, and having an eagle eye. How do you assess how well they fulfill those expectations?
Well, I mean, I think that's what the power of a data-driven skills quantification program allows you to do, right? Because without that data, everything that you're evaluating from a technologist's performance and your throughput, your efficiency, your image quality is all somewhat subjective. So having a program where you have powerful data-driven skills quantification, I think that's step one. And then step two, it's how do we develop the KPIs that we want to track? And then step three, as kind of as from an administrative standpoint, how do we make sure that we're able to provide this feedback to our technologists so that we're empowering and enabling them to become better techs, right? So how do we use that data not to punish them, but to empower them?
So Derek, in your explanation, you just described the three steps essential to this emerging model. So the traditional model, of course, is just like initial certification. It's static, maybe one time or annual, with periodic and continuing education that may not necessarily be pertinent to that technologist's current scope of work. And then with informal supervision, which is becoming fewer and more far between, given remote scanning and the unavailability due to staffing shortages of supervisors and radiologists. But in the emerging model, you've just explained those steps of developing, data-driven key performance indicators, measuring those, and then the essential part is having some type of feedback to the technologist to help him or her improve his or her experience and work.
That's right. Yeah. And so I had the opportunity from a training standpoint to be able to use some skill quantification metrics with, and I worked with Matthew on this while I was at a previous employer. So, prior to having any type of feedback loop, technologists would come, they would, sit down and work through their didactic training, kind of unsupervised. They would work clinically with their technologist partner that was providing the training, and would just kind of progress. But we never really tracked how they were doing. We never really understood what a successful outcome was. And so that did two things. One, it gave us lack of consistency when it came to the output from our training model. And then two, because we weren't doing a great job of having any kind of data tracking over time other than are you kind of hitting your milestones, that timeline got expanded. So we started using skill quantification that was data driven to look at how are the technologists performing. And so we were using a MR simulator that allowed the technologists to go in and scan repeatedly these different body parts that we would be expecting they would scan when they got on site. And it would score their performance based on predetermined criteria to a standard. So what we would see and how this was really beneficial for our team members is weekly I would meet with them. I would give them their assignment, so they'd have their didactic portion they would have to do, and then within the simulator they would have their clinical reps. And it was really important for me, and what we came to find out is that if we want them to get better quickly over time, the primary driver to that is getting a lot of repetitions with feedback at the end that so that it's kind of like iterative so that they can take that feedback and improve over time, right? And so we were seeing technologists come in that first month, they only did their didactic training and simulator training. So on day one, when they were actually showing up to train with the on-site technologists, they already had hundreds of reps in scanning all of these. So they weren't showing up asking, what is an axial? What is a sagittal? What is a T2? They were already on day one able to start comping some of their exams toward the registry. So it greatly accelerated their cross-training. When they showed up on site, they weren't seen by the technologist that's already probably working overtime as more work or a burden.
Right.
They were an asset, right? So they showed up as an asset, and we were able to greatly compress that training time. And weekly, I would just follow up with those team members during their training, and we would review the data. We would review the feedback, and if they scored a 10% on their first brain, I told them, look, that's fine. That's okay. It's a starting point, right? What
Right.
we want to see is progression over time. So as long as your scores are improving over time, you're doing fantastic. So for us, it was a great tool in that respect for really getting consistent results from training
Mhm.
and compressing that timeline.
That's just a great overview of the program. And Matthew, you had some hand in this. What is your perception of it? What was your experience?
No, I mean, all I've been trying to build when it comes to skill quantification is the thing that I wish I would have had as a student, what I wish
Yeah.
my students would have had as a professor, to be able to oversee a lot of my students at the same time and give them meaningful feedback. And then what I wish that my staff had as a director, and how could I differentiate if I'm going to hire you? How could I differentiate? Let's say everyone talks a mean game and everyone looks great on paper, but if I'm going to invest in 5 people that are all fantastic, how can I really measure their performance? Because I can't have them come and scan for me for a day. It can't. Well, there's no working interviews
Right.
in radiology. So I mean, I was happy to work with Derek. A lot of these things that I just hypothesized when I started working on these things, but it was great to watch Derek start to use them and leverage them to not just say, hey, go sit next to someone for 8 months and I'll see you later, hopefully. It's, I know that you are ready to scan patient brains. I know you're ready to, you can do this, this, this. And it was great to be able to see how skill quantification can bridge that gap in a responsible and sustainable way.
You have like real confidence in their abilities as objectively quantified. Now,
That's
Matthew, you mentioned the word gap. Laura, I'm interested, Laura, in your supervision of technologists and your promotion of skill quantification. Have you seen particular gaps that have been highlighted by this more objective approach?
oof.
So
Or
gaps in the
gaps in
objective.
terms of deficiencies in the training or
Oh,
the ability or the competency of the technologists that you supervise and evaluate?
well, so definitely, right? Because again, they're not getting this like targeted micro learning.
Right.
Right. It's, they don't have that up front. They're literally taught how to, and quite frankly, I mean, it's how a lot of us started, right? I started that way, when I first did MRI. In the first 2 weeks, I could scan, most body parts. But at that time, I learned what that meant to be a button pusher. I knew how
Yeah.
to push all the buttons and make
You,
the machine go,
you were
but
you were
I was,
certified, Laura, to push buttons, but you may not
right,
yet have been proven
correct,
quantitatively to be a
right,
high performer in exhibiting those five metrics
right.
that you mentioned.
Exactly. So, and that's where I think that and everyone takes criticism differently. So to like Derek's point earlier, right? You don't want to have it disciplinary. It needs to be truly coaching
Mhm.
in a transparent standard of where it's, call it a scorecard, but not an audit, because an audit always makes you feel like you're being truly graded. But
Right.
if it's blind, it should be blind, not compared to your peers, compared to averages of here's kind of where you are with everyone else. And here's where let's work on these items. It's going to help you. Here's what we're trying to do to help make your life easier, make your job easier, right? Because no technologist wants to have a radiologist say, bring that patient back, right? Uh, no matter how much learning you've had or not had, right? You still don't want that. So I think that that's really important. It's to have exactly like what to have that case-based learning, targeted micro-learning, and in a coachable way.
Excellent.
Mhm.
Any thoughts, Derek or Matthew, about particular gaps where they occur, the gap between certification and performance that this concept of skill quantification may address?
Yeah, I
I,
would see, performance gaps quite often when it came time for individual evaluations, whenever
Okay.
those occurred annually. And soft skills that a technologist may have, such as being really good at patient care, were really good at masking clinical deficiencies that they might also have. So
absolutely.
I was in the room so many times when we would have a technologist that we all knew was poor when it came to clinical competency. But because they were so good with patients and so good with the customers that they serve, they would continually get high marks when it came to their performance,
Yes.
right? And that's a disservice to the technologist, really, because they're not being given the feedback that they need to be given, which is and it's so much better when it's data driven and it's not subjective, when it's objective that, hey, here's how we've quantified the ability that you have to be able to scan a brain, a cervical spine, and knee compared to, the industry average or whatever. It looks like you're, deviations below where you need to be. So how do we help you get to where you need to be, right? So that they're actually building their clinical skill instead of just having that be pushed under the rug because nobody wants them to leave because they're a fantastic tech. They take really great care of the patient, right? So I've seen that gap when it comes to just evaluation of current team members.
And
Excellent comment.
yeah,
Matthew?
No, I love everybody's comments because everyone's lived this. I mean, this is a very personal problem for us that we've either had ourselves and had mentors that we were lucky enough to be around, and radiologists that would take time and very sweetly explain, in elementary school terms at first why certain things were important, and that's the difference. That's the difference between me and someone else. It's luck, it's opportunity, it is a network, and it's getting
Mm,
worse and worse because radiologists have less and less time. Our scans are speeding up, so we have less and less time to actually mentor anyone. And then it just gets worse and worse. It's like MRI and CT is a bad game of telephone. Like, who are you lucky enough or unlucky enough to be
mhm,
around? But gets a little bit worse. I think a gap that I see when it comes to accreditation, I think the ART does a great job. I think that ARMRIT does a great job on trying to create a standard, but a lot of those standards, especially clinically, are based on a lot of assumptions, and all that really comes at that is a technologist. Did they sign off on your certain number of examinations that you had? And and that's the thing. Who is that technologist? What's their skill? Do
Right,
they have any business at that point? So, and who has the time, literally, if we're talking about this, a way to
right.
objectively assess, in Derek's case, 500 technologists, who has that kind of time? Who has that kind of money? It's impossible.
Matthew, you mentioned, evaluation by another technologist. Um, you introduce yet another subjective element in the evaluator using subjective criteria to subjectively evaluate a technologist. And it's very unsatisfactory because, as Derek so well articulated, that, a whole, very good soft skills can hide a host of deficiencies on the technical and clinical side. And it's so important. It's a disservice to the patient to have a technically inferior exam. The first of the many metrics Laura mentioned is image quality. That's the whole purpose for the exam. And any amount of good patient skill is just it goes to the wayside if you don't have a good exam.
And I think it's also a disservice to the technologists themselves
Mhm.
to because no one wants to be bad at their job. No one
Yep.
wants to be a button pusher, but what have we ever given people other than our time and repetition? But I can only teach one person.
Right.
right.
I'm the bottleneck at that point in time, and my schedule is the bottleneck. Have we really ever given people the tools necessary to be successful?
Right.
Mhm.
And the answer
And,
is no. So
and
it,
and and don't forget, like the last point here, the new imaging technologies, right? The only time a technologist learns those new imaging technologies is when their facility or hospital gets that new magnet or gets that new software
Mhm.
to perform those studies. So you're trained in isolation in a vacuum, not across the organization, across the industry, really. It's access. So there also is something we should address eventually is technologist access to this training.
Mhm.
yeah,
And
A-
Yep.
with respect to, oh, go
internet
ahead.
access, absolutely.
Mhm.
With respect to these new technologies, and Matthew, you before mentioned CT and MRI specifically, that there are unique skill challenges pertaining to each of those. And as radiology is becoming so subspecialized, for example, I'm a cardiovascular imager with my own set of, esoteric protocols
Mhm.
that when a facility or a radiology site introduces a new, subspecialty, the technologist kind of has to learn on the job. And so I'm kind of interested in what are the unique skill challenges pertaining to these two different modalities of CT and MRI, and also particularly pertaining to what Laura mentioned is new imaging technologies in general.
I talked a lot last time, so Derek or Laura, you guys go first.
Well, I mean, I don't know that I would say there's a big difference from a training perspective between from CT and MRI,
Okay.
as you approach the technologist. Obviously, there's a difference in CT and MRI, and I am MR and CT registered. So, uh, but from that training, it still requires that someone has to come alongside you and teach you. teach you, and not just teach you the how, but also the why, right? Because that's the difference between, again, right, what, was always called the button pusher versus being the technologist of understanding why you're doing what you're doing and how to overcome when a problem arises,
Hmm.
how to get around it. And, again, and this is where, like when we talk about like protocol adherence, um, to me, I include that, right? I have a protocol, but protocol adherence also means I need to know when I'm supposed to think outside of that and say, okay, I need to add, I need to deviate. There's a reason I'm deviating. I have to get the result here. So I wouldn't say there's different challenges between the two. The challenges are the same. It's and to your point, especially on cardiac CT, yeah,
Yes.
that's even gets tighter. That's a niche window of CT technologists who are truly trained in cardiac
Mhm.
CT imaging. Um, it's not just it's not a head and abdomen pelvis. It's there's different things to it and understanding it, and they really do have to have an understanding. And you have some technologists who take that on and say, I want to learn more, and they'll actually go seek opportunities to learn more. Um, but that one probably does require the radiologist involvement or the cardiologist involvement, whoever's reading, to help teach them specifically on their protocol. It would be nice for some, I think, that they learned that one protocol and not the broad cardiovascular imaging
Hmm.
protocols and why. They learned one way and not maybe the all the ways.
Yeah. I think for me, the only thing that I see different, because I think the same kind of skills need to exist, right? You need to be
Hmm.
consistent. In MRI, additional slices, for instance, cost us time. And
Yep.
I think any slice that you have that you don't need is that's a patient care issue because I could get that patient off the
Hmm.
table faster. And that, the administrative side of things loves all of that because if I get the patient off the table faster from a claustrophobia perspective, they get the patient off the table faster from a efficiency and overall imaging numbers and reducing
Hmm.
backlog and that kind of thing. I'm also a registered MRI and CT. I've done both for a long time.
Hmm.
The thing that I've noticed in CT is that it takes a longer time for people to start to actually prove competency on a CT because you're injecting maple syrup into the patient. You're giving the patient radiation. There's a lot to it. There's more fear on that side,
Right.
and then you compound that with much faster exam times, and you start to. I think MRI with the newer AI enhancements and making scans faster. I think it's going to get worse in terms of the time that someone has to actually explain physics concepts or explain the why if the examination is already over. So
Hmm.
that's the idea there. And I think one more little thing that that Laura was describing is that kind of that feedback loop. Uh,
Hmm.
it's one thing to have to quantify someone's skill. It's another thing to then be able to give them a meaningful intervention of mentorship and explanations to be able to grow them in that
Yep.
way and increase that skill.
One problem I see, and Derek, you may want to speak to this, is we're talking about, the need for the supervision. Matthew, you just mentioned it, and Laura, you mentioned the need for, the new modules on the job training. You kind of need sometimes the radiologist who may be a cardiovascular imager to provide that partnership with the technologist to let him or her know what he or she wants in terms of the product. But Derek, with remote scanning, how is that both a good thing and a bad thing in the sense that it removes that in-person partnership on site, but at the same time, it may be able to provide it. Can you comment on, these new considerations related to remote scanning?
Yeah, I mean, you're exactly right, Dr. Hyatt. I would say one of the largest challenges for technologists currently, and it's only exacerbated when
Yep.
the technologist is utilizing remote scanning and scanning offsite, is that a lot of times at larger imaging centers or kind of enterprise level companies, it's typically a radiology group. And often there's no one radiologist that's you're able to reach out to it quickly or efficiently to be able to help, even sometimes driving what should the protocol be? Even if you take a step back, not just, hey, is the imaging I did on this patient okay? Do you need me to add anything post-contrast? But just what should the protocol that we run at this facility be? Can be challenging when it's coming from a radiology group, especially when you're an off-site imager that's maybe not even an employee of the facility that you're working for. Those lines of communication become very strained if they exist at all. So that certainly can be a big challenge when it comes to the consistency of the product that you're outputting as an imaging center or enterprise company. On the other hand, I've seen radiologists who have used an offsite um, command center to be able to remote in during a cardiac MR and provide feedback on the post imaging that they're doing, to ask for additional scans, to flag scans that had arrhythmias and want repeats. So it's certainly, I would say with that kind of new technology, it's a double-edged sword in just about every aspect of how it's
Yes.
deployed. Yeah.
I used to be, side by side with my technologist at the MR scanner for these
Yep.
inordinately long cardiac scans. Some because, we were new at it at the cutting edge at Stanford. Sometimes they would take 2, 3 hours. And so the nice thing is I was there in person learning from my technologist and the technologist learning from me. But then oftentimes that kind of limits us to when I can be there.
Exactly.
That's right.
So that's where where I go remote is a bad thing in the double-edged sword. But the good thing is that remotely, wherever I may be, I can actually call in and observe and partner
Yep.
virtually.
Yeah, you can be at your home in Maryland,
Yep.
communicating with a technologist that's scanning from Alaska, a patient in Texas,
Yeah.
right? So yeah, it certainly alleviates that pressure for you to be on site during those types of scans.
And at RadSite, we've been really wrestling with this whole new concept of remote scanning, which is a great benefit in terms of addressing the staffing shortage.
Hmm.
It really provides, I think, a greater access for patients in light of the shortage. And but in this time of upheaval, we've been trying to seek standardization and still maintaining consistency with remote scanning.
And I think if I could add one more thing there is that right now, predominantly people that I got Derek scanning for me across town. He's in my same organization.
Okay.
Maybe he knows spectroscopy, I don't. That's one way to bridge that skill gap in that way. Doesn't have to sit in traffic. So I think remote scanning is fantastic for reducing and addressing the difference in skill. But I also see what's coming is the Uberization of
Mhm.
remote scanning to where I don't know you, you don't know
Mhm.
me. I don't know what skill you have to begin with. I know that how do I guarantee that you're going to be able to provide the image quality that I need, the standard that I have in my organization. So
And
go ahead,
and
Derek.
thus, Matthew, the need for skill quantification, objectively assess for these conditions in which you don't know who your partner is.
That's right. So, I mean, I think skill quantification can be growing the infrastructure of the low skill technologists to be able to ultimately be in that position to make a large difference long term. But
Yep.
I also think that responsible remote scanning has to be centered on skill quantification. Um, I mean, I'm personally working on algorithms that I can tell if you are scanning and you are under the influence of something. I can see if there are three people that are posing as the same person. Um, I can be able to see how much they deviate from a standard. So whereas right now the hot topic in remote scanning is on-site safety. I think that in some cases I see remote scanning being safer because any problem safety wise happens with I thought you did something, you thought I did something, and there was a gap. Whereas if I'm remote scanning, you know what I'm doing, and I know that there's the person on site that's responsible. But I think a deeper talk that we have to start getting toward is how can we sustainably know the skill of the person and
Yes.
identify fraud of those people that we don't know, and identify if someone is drunk on a beach, wants to make a couple extra dollars and offset their vacation, and who ultimately pays. It's the patient. So I
Yeah.
think skill quantification is very exciting for when it comes to quality and sustainability.
Yeah, I
Wow.
agree. I agree. Like Matthew, when I was working with facilities that were considering remote scanning, and using outside resources to cover, trust was always the currency that they were concerned about, right? How can I trust that person
Mhm.
that's scan? So I think doing some type, like you were mentioning, working on algorithms that can do some kind of inline trust verification allows them to be able to kind of trust but verify that this person is doing a good job, but now I have quantitative data that's making sure that that's the case.
Laura, I'm wondering, with the technologists that you work with, what do you think the reaction would be to such surveillance? To me, in a way, it seems like appropriate to assure patient safety, image quality, protocol adherence, and efficiency, all of which you've spoken about. But on the flip side, would some of them feel uncomfortable by such close surveillance?
Well, of course, it's human behavior, right?
Yeah.
Nobody wants to be told they're wrong.
Yeah.
Sometimes you're dealing with an ego of I've been doing this, how many years? Don't correct me. So I mean, but that's the nature. Unfortunately, it's the nature of when you're managing people in any role, whether it's
Yeah.
remote scanning or anywhere in any industry, right? People don't like to be monitored. They don't want to be again criticized because they'll take it as criticism no matter how you intend it to be, right? Um, so I think that's how it's going to be. There'll be those that will welcome the feedback, especially what I have found so far is the newer technologists coming in that they
Hmm.
welcome it. They're hungry for it. They want to learn. They want to know more. They want to understand.
Hmm.
It's been harder with you know, those of us that have been around for a lot longer. Um, that it's an important concept and it's something that I'm going to really go back to one of the things that I learned in my radiology program. We had to carry a notebook, and
Yeah.
our director made us write something every day that we learned
Oh,
because the lesson was to never stop learning, to
never stop
always
learning.
be opening that you don't know everything. Because you'll reach this point in your career where you think that you do, but you don't. It's always changing. You always have to be open to something new. And it's not that you did something wrong.
Yeah.
It's just that there's another way. There's some improvement that have been made. Um, or to that point of, hey, you're working with a new radiologist, and this is what they're asking for.
Mm.
You know,
That's interesting, Laura. You're speaking of when you were a student, which was probably more than 5 years ago,
yeah,
and how you used a notebook.
right.
And now our students are using such fabulous technological tools to assist them in their education, training, and performance. And I'd be interested in knowing from the three of you how technology is being increasingly used as a support.
I think I don't know, Matthew sounds like he's already onto something, which is excellent because from an operation standpoint, right, you don't want to add more labor to your already existing labor force. And in order to track and measure quality right now, it does require a lot of manual intervention of someone reviewing cases, grading cases, right, providing the feedback and the coaching. Whereas if you have tools that can provide a lot of that for you,
Yeah.
and even in real time, right? AI in real time to say, hey, this image quality is
It-
bad,
it-
or yeah, or even to understand artifacts. I mean, technologists, many of them don't even know. They know
yeah.
there's an artifact, they don't know what it is. I mean, there's a lot of learning that is just
And,
missing.
and Laura, Matthew had previously mentioned, I believe, with respect to protocol, automate AI guided automated protocol support. Is,
Right.
is that is that a real thing, Matthew?
But I think I am not anti-AI by any means. I wish it used less water, but on my side, I think AI should be an enhancement, not a
Okay.
replacement for technologists, and I feel very strongly about that. Um, But I also think, I mean, what is the AI trained on, for instance, to automatically angle? It's graded, the ground truth that it's based off of is based off of 20, sorry, I was about to say radiographers. I've been traveling recently. 20 texts that if we all scanned your same brain, Dr. Hyatt, would we
Mhm.
all scan it the same? And the answer is absolutely not.
Yeah.
And that should be scary to everyone. It's great to have the MR certification. It's great to to
Mhm.
to have great, wonderful patient care skills, but at the end of the day, who are you really? And if AI is based off of a ground truth that is the original problem to begin with, a lack of standardization, I think that again, it doesn't solve the issue because it's
Mhm.
based off of the problem.
Right. Yeah. And it's probably it's probably an 80/20 rule, right? Where you could apply it to 80% of the time, right? But it has to be symptom based, not
Mhm.
just not body part based, obviously. Because like to Matthew's point earlier, right? Scanning a brain for MS, that should be consistent, right?
Mhm.
And it's where you need consistency. And unfortunately, you can't control where patients go. And it could be their insurance plan that drives them from one MRI clinic to another MRI clinic, in network, out of network. So they're somewhat forced from financial constraints to now move to a different facility. And now they have their scans don't match, right? So now how do you, right, track that progression? Yep.
And why do I jump into a Uber with someone I don't know? Why? I mean, it's the opposite of what my mother taught me to do. You literally
Right.
do that.
You
Right.
got in a stranger's car.
Yeah, but we do it. And that's because that Uber driver has a score and they've had experience and we can check it. So
Yes.
why
Yes.
is that acceptable for our drivers and not acceptable for the technologist? I'm all of a
Yeah.
sudden pretty old. I'll be dead soon, uh, especially with the stress. But ultimately, I'm not far away from being that person on the scanner. I want me, my loved ones. I want people to have
Yep.
the I want them to have a great standard of care. And until we have a skilled labor force, there's no way that we can know that.
Matthew, this is such an important topic, and all of you have really given good insights. I'd like to conclude with some of the practical things that those in our audience, as part of imaging organizations can do to really apply this concept of skill quantification to make their technologists better, ultimately to improve imaging for patients. Derek, do you have any thoughts?
I mean, when I reviewed this slide, I think it's the bullets really lay out a good programmatic approach to how you would solve this, right? So, step one, we have to define what is competency. What does that look like? What are those KPIs? And then two, adopting a technology that provides quantitative feedback, whether that's on image quality or it's on clinical scores based on how your technologist is scanning. Are they using the appropriate fields of view, the appropriate slice thickness and spacing? Are they covering the appropriate anatomy? Are they angling to the appropriate anatomy? Um, and then integrating that into their training, because training shouldn't be, hey, we've got your 6 to 12 weeks, pat on the back, here's the chair, get to scanning. It shouldn't end there, right? Our training for technologists should continue through the course of their employment with whatever employer they're with. That's the only way that we're going to make sure that a skills gap doesn't occur. As we've talked about, the technology is continuing to advance. How do we make sure that our training during their time while they're with us continues to advance along with the technology? So having some kind of data-driven performance feedback that we can review with them, quarterly. Because one of the things that I hated when I would get performance evaluations was if I got a surprise on that evaluation, I felt like that was bad leadership. Like
Yeah.
if there shouldn't be anything that you're telling me for the first time when at a performance evaluation that I wasn't doing well. Like you should have told me at the moment I wasn't doing it well, right? So having that data-driven insights, I think makes it much more amenable for the technologist to be like, oh, okay, I'm not being targeted. You're not This isn't because of some vendetta you have because you don't like me. This is just my performance. All of the emotions taken out of it. It's very targeted to my clinical deficiencies, and we're going to work together on a plan to improve those. So I guess, and then the last piece is just so now that we have all of this data and we've created the skill measurement and we've agreed upon what the KPIs are and we've developed a program to roll it out, are there going to be accreditation standards that are going to unify this, not just for my employer I'm at today, but really across the industry?
Just excellent advice, Derek. Matthew or Laura, anything you'd like to add in conclusion?
Yeah, no, I think not to add more regulation because that's obviously not what we're here to do either. It's to hopefully replace, right? If it's kind of like an MRI sequence, right? If a radiologist wants to add a sequence, I'm like, which one are you taking away?
Exactly.
Right? Yeah. So, but we have peer review, right, of the radiologist reports. And internally, there's organizations that do this technologist peer review where they have their own KPIs, what's important to them as a practice. And this is where that would kind of come in, that, and maybe even as a accrediting organization to start looking at that and saying, do you have something? Show us what you have to ensure quality, to ensure, consistency and competency of your technologists.
Yeah. And I would say the important thing here in terms of integrating something like this inside of your whatever school, hospital system is messaging. This is not should not be used for evil. This should be used to identify an area, an opportunity for improvement, and that's got to be the message that everyone is putting out there to their technologists, because technologists are, I don't think we've ever been a good technologist. I don't think we've been more appreciated in all my career than we currently are right now. And I think that we want to keep those people, right? And I don't want just beating heart people that are sitting at a desk and pushing buttons. I want to be building them up. I want to retain them. I want to be investing in the infrastructure without making my day harder, to be able to slowly be building the skill gap, to be able to address that internally and through hiring and remote scanning. It just goes on and on.
Excellent. We want competent, caring technologists. And I think skill quantification, as you've also well articulated, may be a means to achieve that for the benefit of the technologist, him or herself, but ultimately for the patient.
That's what's important.
I'd really like to thank Matthew, Derek, Laura. You've been excellent panelists, and would like to turn the time over now to Kristen, our hostess.
Thank you. We did get one quick question. So we have 3 minutes, 2 minutes. I'm going to pose one of the three questions. It's from the same person. So we will email this person if we don't get through everything. Can I ask one of the questions?
Sure.
Okay. Do you have a specific competency evaluation form and expectations for repetitions that prove competency that is reviewed with a technologist?
So I would say, so RadSite does not have a competency evaluation form. Each organization comes up with their own and presents that to RadSite as part of their remote accreditation application process. So it's something that we review. We look at the KPIs that they're going to be tracking, and we provide feedback. So, and remember, that's something that's very important to RadSite, is providing feedback and education. Again, not penalties, not tell you that you're doing it wrong, but make a recommendation of, this looks good. We recommend that you add this KPI or track it in this way. So currently, no, there's not a formal form out there.
All right, perfect. Thank you, Laura. And one other part, how do you ensure continuing competency and prevent laxity?
I would think that I worked at a large organization, right? And they rhymed with G-mins. And every couple of weeks, I would have to maintain my profile. I would go in and that could be CPR training, that could be how to deal with a spill or something like that. I needed to maintain that 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 profile. And so I think skill quantification, I mean, ideally should be something that is repetitive, and the more time points that you have, then you can actually measure and watch improvement and monitor consistency all within the same area. So that would be,
Yeah. Yeah.
Okay,
And I would say
wonderful.
that depending on the size of the organization, right, they may already have a team in place that can assist them with that, or they can reach out to um, externals that could maybe be able to assist with that.
Okay, wonderful. Thank you very much. I appreciate that feedback. Site would like to thank our moderator, Dr. Mark Hyatt, and our panelists, Matthew Hayes, Laura Casa, Derek Rischel. Just a reminder that today's webinar has been recorded. Please visit our webinar page on RadSite's website at www.radsitequality.com or our YouTube channel for this webinar recording and past webinar recordings. If you'd like more information about RadSite's accreditation programs, contact us at info@radsitequality.com. Thank you so much for joining us today. Thank you, you wonderful panelists, and we look forward to seeing everyone again at future webinars.